my dear friends. Namaste and good evening. Thank you, each and every one of you, for being here with us today. We are very pleased to be able to welcome you to this virtual CME. The topic is very relevant as sub-specialty programs in subfertility is being planned in Nepal soon by National Academy of Medical Sciences, Institute of Medicine TU Teaching Hospital, and National Board of Medical Sciences of Medical Education Commission. Our guest speaker has made a powerful contribution to the field of subfertility and IVF in Nepal, and is also working with the Department of Reproductive Medicine and Infertility at Parapakar Maternity Women's and Women's Hospital, Thapathali also. You all are aware that NESOC arranges CMEs in relevant topics every month. I feel proud to welcome our guest speaker today in this virtual gathering. Dr. Sanu will be delivering our presentation on IVF in the next hour or so. I'm sure we'll learn many enlightening things this evening. Finally, NMC CPD credits will also be provided to those who attend it fully. So please stay tuned till the end of the programs and support our program. Friends, this is all from me. Thank you everyone for being here this evening. Thank you. Over to Dr. Smriti, please.
Okay, thank you so much, sir. Our presenter today is a very well-known doctor in field of infertility and obs-gynae fraternity, none other than Dr. Sanumaya Shrestha Pradhan. She is Senior Consultant, Gynecologist, IVF Specialist, and Managing Director at Creators IVF Nepal Private Limited, Saddobatu. Dr. Pradhan has completed her MBBS from Ming State Medical Institute, ex-USSR in 1991. She did her diploma in obs-gynae from TUTH in 1995, Master of Science in obs-gynae from University of New South Wales in 2004. She trained in infertility management and assisted reproductive technology, TVS for infertility in assisted reproductive technology from Royal Hospital for Women's, Australia. Let us welcome our speaker for today, Dr. Sanumaya Shrestha, for our topic, that is basic of IVF and IVF during COVID pandemic. Welcome, ma'am.
Please unmute yourself.
Thank you very much, Dr. Ganesh, Professor Dr. Ganesh, President of NESOC, and Dr. Smriti for your kind introduction. I'm going to present on basics of IVF and IVF practice, challenges of IVF practice in this COVID-19 pandemic. Should I share screen? Slides?
Yes, ma'am.
So today's topic is basics of IVF and IVF during COVID pandemic. Actually, I'm going to give a very basic of IVF and how difficult IVF treatment was during IVF pandemic, COVID pandemic, how we experienced and how we responded to those challenges I'm going to speak. So let's begin with what is IVF. So IVF, it's literally like when we say in full form, it's in vitro fertilization. Vitro word is that English word vitro is derived from Latin word vitrus. Vitrus means glass. So hence in vitro fertilization literally means fertilization in glass. So the fertilization happens outside the body in glass in IVF. And the fertilization that occurs inside the body is called in vivo fertilization, which we all know. So we all know like where fertilization happens inside our body. So it happens in the ampullary part of fallopian tube, and fallopian tube, when the fertilized ovum will be transported to uterine cavity through fallopian tube. So let's say, who are the candidates for this IVF treatment? So it very absolute indication for IVF treatment is for those women who have both tubes blocked, bilateral tubal block. And the other candidates for IVF, those who had already received assisted reproductive technology like IUI in past and at least 6 cycles. We say 6 cycles, but if the female's years is higher, then we go up to 3 cycles of IUI. If they fail, then we go to IVF. And those women who have proven an ovulation also go for IVF. And females who have advanced years, they also go for IVF with donor oocytes. And the other one, like male factor, severe oligospermia. If male has severe oligospermia, we go for IVF. This will be, the rest will be classic standard IVF. This will be, if severe oligospermia is there, then we go for intracytoplasmic sperm injection. So let me explain this IVF in. If we explain IVF, we can explain in very simple, in three sentences. Like, see, in IVF, mature oocytes are retrieved from females' ovaries. Just a minute. In IVF treatment, we retrieve mature oocytes from ovaries, and they will be fertilized by prepared semen sperm in embryology lab in petri dish in glass with proper culture media. And this fertilized ovum is known as embryo, and the fertilized ovum embryo is then transferred to uterus, as I have shown in picture. So we retrieve egg from ovary, we fertilize in petri dish, and that fertilized ovum will be transferred to uterus. This is it sounds very simple, but for this treatment, we need to pursue this treatment well. We need a well-equipped embryology lab, well-equipped andrology lab, well-equipped oocyte retrieval setup or ovum pickup room, well-equipped OPD and hormone storage setup, because hormone is so sensitive. If you don't maintain your cold chain properly, the effect will be none. So that's why we need really good hormone storage setup too in this, among those all above. And IVF treatment is a teamwork. So in this team, there should be qualified and well-skilled gynecologist, qualified and well-skilled embryologist, qualified and well-skilled andrologist, qualified endocrinologist, and well-trained IVF clinical nurses. Very important role. We see very, very important role with clinical nurses too. And well-trained technical support team, because we need lots of technical support in IVF lab, for embryology lab. So now let's explain like how we do IVF, how we treat patients, right? So in IVF, in natural cycle, only one follicle will be dominant. On day 6 of your menstrual cycle, natural menstrual cycle, the dominant follicle selection will happen, and then the rest follicles. During day 2, 3, they are like in non-PCO cases, there will be 5, 6 antral follicles will be recruited in menstrual phase, and out of that only one follicle will be dominant. That will be, the selection will happen on day 6 of your regular menstrual cycle. So in natural, only one follicle is obtained That's why we need more oocytes. We need more follicles. In IVF, when we do fertilization outside the body, we need more oocytes. That's why we need to stimulate the ovary to recruit more follicles. So for this, we need to break the control over ovary, like that dominant follicle selection, one follicle selection control should be broken down. So for that, we need to give either long GnRS agonist continuous, that is agonist protocol we say, and or antagonist protocol. So that will break that SPO axis and we can get more eggs. So that's why we do controlled ovarian hyperstimulation with exogenous injections of follicle stimulating hormone, either with agonist or with antagonist protocol. And then we monitor patients, their follicles by transvaginal ultrasound, and we do serial hormone assessment, estradiol assessment, estimation, like during like every alternate day. Okay, first 6 days we give continuous follicle stimulating hormone. Then from day 6, we will do hormone estimation of estradiol on day 6 of stimulation. In long protocol, I'm saying, not in antagonist. In long protocol, we see on day 6, we do transvaginal ultrasound and estradiol level, and then we will adjust our follicle stimulating dose in antagonist protocol, agonist protocol, long protocol. But in antagonist protocol, we will see on day 4 of ovarian stimulation whether at least one follicle is 14 millimeter or not. If 14 millimeter, then we'll start antagonist just to prevent LS surge. Okay, so once at least 3 follicles become mature, that is more than or equal to 18 millimeter, then we'll give human chorionic gonadotropin to the patient for final maturation of oocytes. We all know that primary oocytes are arrested at diplotent stage of prophase 1, meiosis 1. So that will be completed when naturally when LS surge happens. So these patients are in IVF, all patients are downregulated. So they need exogenous SCG. That SCG simulates LH surge. So this is artificial LS surge we are giving for final maturation. Then after 34 to 36 hours of SCG injection, ovum pickup is done under anesthesia. This will be IV sedation and under the guidance of transvaginal ultrasound. You can see here the needle is going through that in ultrasound in ovarian stimulated follicles looks like this, and this is the needle under ultrasound guidance we are seeing. And then these mature follicles are mature means I've already said more than 18 millimeter, and all small follicles also we aspirate. We aspirate all follicles into the tube, test tube with negative suction of minus 200 millimeter Hg. The tube is then passed to the embryologist for oocyte screening. So those screened oocytes are then kept for fertilization with husband's prepared semen in laboratory environment. And fertilization check is done 18 hours after insemination. So fertilization is indicated by presence of 2 pronuclei. So this picture you can see 2 pronuclei. And then embryo develops in culture. This day 1. So here day 1, that's fertilization check, and day 2 cell, then it doubles 4 by 4 that's 16, like it doubles every day, and we transfer embryos after 4 cell stages of state. And culture, it's very interesting, like this culture media where that fertilization occurs and embryo development occurs are designed to chemically mimic the fluid in women's fallopian tubes and endometrial cavity. So initially when like the IVF was developing, it was long back, it's actually many years it has been worked on to develop culture media. Then after like they have worked on how the fertilization occurred, how this works with the all media. They worked hard and they found mimicking, simulating fluid. They developed simulating fluid that's culture media for fertilization and embryo development. Now in present days, we have many kinds of these culture medias. So on day 2 or day 2, 3 or day 5, on day 5, we transfer blastocyst. Day 2 or 3, we transfer like 4 cell stage or more. We transfer embryos to the uterine cavity under ultrasound guidance. So like that we transfer. So on day 14, after embryo transfer, on day 14, post-embryo transfer, we see pregnancy will be checked by serum beta HCG. So here we can see like that's clinical pregnancy, positive clinical pregnancy. It sounds like it should be, everybody should be pregnant in IVF. It sounds, because we develop embryo outside the body having transfer. So that means even patients are very expecting, oh, I will be 100% positive, but it is not like that. So depending upon couple's condition, IVF can be done using self-oocyte, self-sperm with classic IVF, like standard IVF. If patient is young enough and her husband's semen is fine, then we can go for self-oocyte and self-sperm with classic IVF. If husband's semen is poor, then we have to go with self-sperm with self-sperm with ICSI, intracytoplasmic sperm injection. And if like patient has age factor, she's already menopausal, or like her ovarian reserve is very diminished, then we go for donor oocyte and self-sperm. Similarly, we can go with self-oocyte and donor sperm if azoospermic, but in azoospermia, we first do at least 6 cycles of IUI donor with donor sperm, then only go for IVF. And those who have azoospermia as well as age factor, we also go for with donated embryos. So it sounds like IVF should have very high success rate. Actually, in reality, it's not. So the live birth rate of IVF treatment varies from 23% to 43% worldwide. It varies center to center. It depends on how you like give service, how you treat your patient, how you prepare your patient, how you select your patient. It depends on that. So that's why I really feel like IVF practice, IVF treatment itself is a challenge. It's a big challenge, and this is like you need physician, gynecologist, or whole team need to have big strength and courage, as well as patient has to have strength and courage. So otherwise, this is really difficult treatment. So, so I'm like I was initially given this topic, and then I thought like Professor Dr. Ganesh Dangal also told maybe I need to give some basics too. So I have summarized that very basics. In detail of IVF presentation, I think I'll do in later CMEs. Actually, I have gone through lots of challenges in IVF practice during this COVID pandemic. I'm giving my own experience in IVF practice of this pandemic. So this pandemic, IVF itself is a challenge, and COVID pandemic is a unique global challenge. And this pandemic added more challenge in IVF practice. Out of caution, several professional societies around the world recommended suspending therapy for infertility services initially on March 18, 2020, a week after the World Health Organization declared COVID-19 infection to be a pandemic. Then in first wave, since 14 March 2020, the American Society for Reproductive Medicine, European Society of Human Reproduction and Embryology recommended to avoid the initiation of assisted reproduction technology treatment, except for the most urgent. So the pandemic imposed an immediate dilemma for centers actively treating infertile couples with ART. So Creators IVF, where the center which I'm running, was no exception, since this center was closed for almost 3 months during this pandemic in first wave. And following the initial suspension of ART treatments, patients experienced insecurity and a state of heightened stress. So infertility is a serious disease affecting about 15% of couples of reproductive age group. It harms mental health and social well-being. So infertility treatment is time sensitive, and it worsens its prognosis as time goes with age. So that's why this is on the basis thinking of that, ASRM, ESRE, and the International Federation of Fertility Society came together to jointly affirm the importance for continued reproductive care during the COVID-19 pandemic. And the guideline provided by NESOG in its publication, Clinical Practice for Management of Reproductive Health During COVID-19 Pandemic, has given us the immense support in resumption of our services dedicated for fertility treatment. And so then after the guidelines from different societies, then our center, Creators IVF Nepal, gradually started to provide its fertility care after 3 months closure in the first wave of COVID pandemic. So the challenges which we have faced during in IVF practice during COVID pandemic, I have tabulated. We had challenges in management aspect. We had difficulties in human resource management, procurement management, sanitation of OPD, OT lab, and clinical aspect. In clinical aspect, outpatient department management was challenged, laboratory management, andrology lab and embryology lab was challenged, and in general aspect like fear, confusion, and misinformation about COVID made another challenge. So I have summarized these challenges in 5 categories, like COVID-19 pandemic response, lockdown made us challenge. Patient and staff protection from COVID-19 was another challenge. Smooth lab operation was another challenge. Sanitation of OPD, OT, embryo and andro lab was another challenge. Fear, confusion, and misinformation was the 5th challenge. So I'm going to explain how we had these challenges and how we responded to these challenges. I'm going to explain. So due to lockdown, challenge 1 was the lockdown. Due to lockdown, we had the face-to-face interaction was not possible. All staff attendance was not possible, and many IVF cycles, there was high risk of IVF cycle cancellation. How we responded, like in those cases where we can do telehealth technologies, video conferencing, by phone consultation. We have done that. And for staff attendance inability, we have managed with minimal staff and staff rotation. Similarly, like there was high chance of IVF cycle cancellation. We informed patient, we have taken informed consents prior starting IVF cycle, and we have explained them everything before starting IVF. So second challenge was patient staff protection. This was the second challenge. So how we have responded? We have limiting the number of patients visiting the center. We denied patients from high risk area. We have given appointment-based system to prevent crowding. We have managed social distancing, spatial isolation in waiting area, seats, floor through use of labels, stanchions, and glass shields were arranged where necessary. Mask, hand sanitizer, and personal protective equipments are widely used. So, and we screened staff as well as patient with thermal gun using TRICE questionnaire advised by X-ray, evidence of clearance of if patient or staff has suspected infection, we have taken clearance of COVID infection, then only we allowed them to come to the work. And also we traced source and tracing of COVID-19 we have done through detailed patient history as well as triage questionnaire. And some patients, because of patient negligence and staff negligence, usually patient negligence increased risk of COVID. So all staffs are trained and made aware about transmission and risk of COVID-19, which they can use to spread awareness to patients when there is crowding, absence, or wrong donning of mask, etc. So we have taken multiple classes to the staff to make them aware so that they can teach patients how to be more careful. And we have taken utmost care in formite infection. We have disinfected seats, doors, handles, table, and surfaces by 70% alcohol. And smooth lab operation for us was another challenge. And procurement of laboratory items, media, disposables, oxygen cylinders, liquid nitrogen limited was difficult and limited. Some center has to limit their facility due to some cause. And crowding and interaction we have managed. And transmission through semen and follicular aspirate was still not known during first wave, but still it is under investigation whether it can transmit or not. But although we have taken the precaution. So when we had difficulty in procurement of lab items and those, we have searched new vendors and we have changed vendors to get those disposables, culture media, and oxygen cylinders. And sometimes we had to pay we had to procure in higher cost during this pandemic. And in some centers, like those who do not have in-house embryologists, they had to cut the facilities, IVF, ICSI, TISAS as such. And crowding and interaction, we have, that I have already spoken. I think we have given appointment system, limited interactions with patients, and we have given clear instructions to all the patients for semen collection and etc. So transmission from semen and follicular aspirates was still unknown, though it is under investigation, and though we have taken our utmost precautions. So we practice good laboratory. We have started good laboratory practice, use of PP gloves and N95 masks, processing one sample at a time to prevent cross-contaminations with disinfection in between, installation of HEPA air filters for added safety, surface disinfection of semen containers, proper oocyte and sperm washing to dilute virus, and raw semen freezing was stopped, were not performed, and density gradient over swim up was applied, and proper disposing of samples, disposables, and gloves were practiced, and storage of suspected semen oocyte embryo in separate liquid nitrogen container and utmost care was taken during time. So like that, we have we run lab smoothly during this pandemic. And the sanitation of transmission through formites was the main concern. So for that, we have disinfected surfaces, handles, table, counters with 70% alcohol in OPD department. Similarly, we have done use of disposable rubber bed sheets and towel in semen collection room. Semen collection room thoroughly cleaned, disinfected after each patient. Separate patient and staff gown that were washed thoroughly at the end of the day. IVI beds and are physically distanced and disinfected after use. Same were done in OT, ET, and recovery beds. Once disinfected, beds are on use for minimum of 45 minutes. That's why we have done even ovum pickups in 1 hour apart in between 2 patients. And the apparatus were thoroughly cleaned after use. Apparatus and instruments, everything was thoroughly cleaned after use. Another fear, confusion, and this misinformation, confusion made staff as well as patient very afraid of coming to the coming to work too. So proper education and awareness regarding transmission symptoms and severity of COVID was educated, and we have done health insurance of all staffs against COVID-19. And also, like once we had during second COVID pandemic, second wave, many staffs were very reluctant to come and work. So we have done PCR testing for CIVF staff as when required, and we made them confident. And also all staffs were vaccinated to respond this challenge, this number 5 challenge. So that's like from first wave till few days back, when we have seen 702 patients were screened since first wave in CIVF. So during first wave, there were no cases among patients reported. But in second wave, we had 7 reported cases of COVID-19. There were 2 COVID-19 positive cases among first trimester pregnant patients. All were recovered. And in second wave, in second trimester, there were 4 COVID-19 positive cases. They were also all recovered. And there was 1 patient who was pursuing 1 patient was IVF treatment patient. We have done her ovum pickup, and Next day, she reported us like she was having some cough and cough and fever. Then we advised her to do her PCR test, and her PCR test was positive. So we didn't continue her treatment. We picked her ovum and we freezed all embryos, and we asked her to home isolation, and now she's already free of her COVID-19, and she's preparing for frozen embryo transfer. And among staff, we have in first wave, we had one reported case among staff. She was contracted from outsource from other hospital where she had gone for her cousin. When her cousin was sick, she has been there and she was contracted from there, and she was also was also treated in home isolation, and she recovered well. And in second wave, there were 3 reported cases among staff, and all recovered well. So these are in details of those patients in first trimester. I'm not going to tell all in detail. And in second trimester, all patients, like they all have recovered. They all have recovered, and now they are continuing their pregnancy. I'd like to thank you for giving your attention. And this is, I just want to say, this is baby Bigyan Shrestha from IVF Nepal, IVF first baby, and this one is baby Srishti Srijana from Creators IVF Nepal, first IVF baby. Thank you very much. Thank you very much.
Congratulations, Dr. Sanu, for such an in-depth and wonderful presentation. We are very much thankful to you. Now to go to our question and answer session, ma'am. Science have always had a magical effect on living beings, ma'am. Our infertility is a stigma, but it's just a statement now. I'm sure this infertility is such a satisfying, challenging, specialized area in our
Ma'am, mute भयो हजुरको
अरे शिव कहाँबाट म्युट भयो
Okay, I'm sorry, Ajay.
Can't see.
Ma'am, can you hear me now?
Yes.
Ma'am, infertility is a stigma, but it's just a statement now. I'm sure it must be a very satisfying and challenging, specialized area. हाम्रो गाइनेको field, ma'am, that we all deal with, and you deal with it every day. Ma'am, your first question, because it's such a challenging thing, you've got many questions. I'm going to go one by one for you.
Sure.
Your question, Aka, was during COH, which factor decides to use agonist ki antagonist protocol?
Okay. So I think if there's no such factor, I think I'll say ovarian reserve. Okay. In long protocol, agonist protocol, we usually give long IVF long protocol. Long protocol is when you desensitize the pituitary, down regulation. First, you need to do down regulation, then you start ovarian. When down regulation is confirmed with blood test, then you start ovarian stimulation. This long protocol has the highest pregnancy rate, and it has, you know, like when you stimulate with agonist protocol in long protocol, you have simultaneous synchronous growth of follicles, and you will get more eggs in agonist protocol. But in antagonist protocol, you can give antagonist protocol to anyone you like. But the drawback of antagonist protocol is when you stimulate, you won't get synchronous development of follicles. That's why, like recruitment, the yielding of the eggs is better in IVF long protocol than in antagonist protocol. But there is one risk in agonist protocol, long protocol, IVF long protocol. There is higher chance of ovarian hyperstimulation syndrome. you can control that. If you have like good sense of stimulating, controlling your doses of follicle stimulating hormone, and if you are good at monitoring of hormone estimation and monitoring of follicular count and sizes, you can control that very nicely. And I love long protocol than antagonist protocol. There's no deciding factor. You can apply to anyone. And in agonist protocol, another one good factor is if your patient's ovarian reserve is low, then you can give short agonist protocol. So that is we call IVF short protocol, or you can say flare protocol, flare. So in this protocol, you will get advantage of flare effect of GnRS agonist. I think I'll explain once. Like when you in natural cycle, GnRS agonist is secreted from hypothalamus in pulsatile regime, right? So that pulsatile regime will stimulate gonadotrophins to secrete gonadotrophins from pituitary. When you give exogenous GnRS agonist, it should desensitize the pituitary, but initially it gives flare effect. So in short protocol, we incorporate that flare effect for stimulation of ovary. So you have good effect with short protocol in low ovarian reserve patients. That's the advantage of agonist protocol. Did I
Thank you, ma'am. I think they did understood, ma'am. Ma'am, अनि अर्को एउटा हजुरले ओभरियन हाइपरस्टिमुलेसन सिन्ड्रोमको बारेमा कुरा गरिरहनु हुँदा यहाँ क्वेसन के छ भने गिभिङ ma'am, do you give carbacholine in stimulating cycle if OHS risk is suspected? हजुर.
Yes. Carbacholine, like you don't give earlier, you will give carbacholine 0.5 milligram once a day from day of pickup. If you have, like, you need to see first how much is your estradiol level, right? If estradiol level is more than 6,000 picomole per ml, 6,000 is, I'm very used with picomole, so I say you can divide with 3.6, then you can get in picogram. If you have more than 6,000 picomole per ml estradiol, then there is high risk of OSSS, and you can freeze all, and then you can give carbacholine from day of pickup once a day till like about 10 days, because this hyperstimulation, if you have your patient have hyperstimulation, that is the effect of trigger injection. Everybody knows whoever are practicing IVF. So that effect, the effect of side effect of this SCG injection, it sustains till 10th day of trigger injection. So you have to worry till 10th day of trigger injection, then after it subsides on its own. So you give somewhere around 10 days from day of trigger. Yes.
Thank you, ma'am. Ma'am, another interesting question is IVF ko success, ma'am, fresh embryo sanga body huncha ki frozen embryo sanga?
That is, it depends center to center, I think. I love fresh cycles. We have lots of fresh cycle success. And also when we compare, today I didn't bring my, like, I don't have this thing like data here. When we analyze 768 cycles of IVF, different type of IVF cycles, we have a little bit higher in frozen cycle than in fresh cycle. Everything we need to talk on the basis of data, right? Worldwide also, like in some literature, they say frozen is better, some fresh. I think I don't want to speak much. I think you need to experience by yourself, and you need to keep your data and depend on data, your data. Let's not depend on others' data. I think we need to keep all our data and analyze and see, critically think, and then decide.
Exactly, ma'am. We all are scientists and we should always believe on scientific data only.
Yes.
Thank you, ma'am. And there's one more question, ma'am. Is donated zygote and surrogacy same?
What is donated?
Zygote and surrogacy same?
No. Surrogacy is different than donated. Donated embryos, donated zygotes, like, for example, patient is in advanced age and her husband is ASO, then we offer them donated zygote for implantation. Whereas in surrogate, patient has no uterus, either no uterus congenitally, or her uterus is already, like, her endocavity is damaged due to Asherman syndrome or due to like tuberculosis, whatever, then you need to hire uterus of another woman. So zygote will be her own gene, the one who was suffering with Asherman or whatever. And that zygote will be transferred to another lady's uterus. That is surrogacy.
So thank you, ma'am. So now the question is, first IVF, if it fails, then what is the time interval for the second IVF cycle, ma'am?
Okay, so I learned this ART in Australia, and like even like all developed countries, what they say is back-to-back cycle is never good in stimulation, right? If your first cycle is with ovarian stimulation, then back-to-back cycle, you need to give some rest to the ovaries, right? So back-to-back cycle means like immediately, like patient failed, and then immediately if you stimulate, there's number one, their stress level will be the same. They haven't yet, like, cooled, calmed. And number two, there is less recruitment of follicles when you go back-to-back cycle. So at least that patient has to have one natural cycle. Failed IVF, she will have period. Then you wait for another natural cycle comes, then you start treatment. My suggestion is that. And I do practice same, and I have good results with this.
Thank you so much, ma'am. Thank you not only for your presentation, but sharing your data and your knowledge with us. I'm sure all of us have gained a lot. And as we are dealing with COVID-19, the nature has shown us another harsh reality, that is our country is suffering from the flood and all the issues. NESOC will very soon come up with a plan of another presentation. I'm sure we'll keep you updated. With this, I would take a leave from you all, and I would like to request Associate Professor Dr. Yam Dua, General Secretary NESOC, for vote of thanks. Thank you very much.
Thank you very much.
Sorry, Dr. Smriti. Dr. Yam has apologized, and Dr. Sapna will be doing the vote of thanks. Dr. Sapna, please. Unmute yourself, Dr. Sapna.
Namaste, ma'am. Thank you so much, ma'am, from the bottom of the heart. And thank you from NESOC Executive and NESOC family. We loved your presentation, and your insight in IVF in this COVID pandemic was very helpful to everyone, because there were a lot of questions during COVID pandemic, whether to conceive or not. And going for IVF or IUI was another challenging, and we got to hear you continuing your work and your effort to continue people's family, getting the family, get to their family, getting life was commendable. And it's very nice to hear that you are still continuing amidst COVID pandemic. And there were so many people got benefited from you. We got to hear, and there were people who are asking, we are not in the infertility area still. There were questions whether to continue or not. These were major questions, and you are doing IVF was very applaudable. And I think here there are so many here in your presentation. Hopefully all will be very happy to hear you. Thank you so much, ma'am. Hopefully whoever is present over here will transfer whatever you have shared to others. Thank you so much. Thank you so much, sir. Thank you so much, Ganesh sir, for getting us here in this platform. Thank you so much. We will more to hear in future too. Thank you.
Thank you.
Thank you so much.
Thank you so much for offering me this opportunity. Thank you so much.
Thank you, everybody. Thank you, Dr. Sanu and all. And I would like to thank Niranjan ji and Enren for technical support. And Niranjan ji will send the list of attendee for CPD purpose, and Dr. Sandesh, I think, has already applied for CPD, NMC CPD, and will get that CPD points. Thank you, everyone. Thank you.
Thank you.